Okay, this is the last of the videos. I know you're tired of seeing me, but maybe not Kathy. Okay, so we're gonna go over sacrum and coccyx. Now, these projections, these series, you may not see as often. A lot of the time, if you're doing a sacral base or a Ferguson or L5 spot on your lumbar, it's not always necessary to do a sacrum in addition because it's almost the exact same image, okay? Coccyx is used a lot of the time if people are afraid they've broken their tailbone, but we all know that they can't really do anything about that, but other than maybe sit on a donut. but we want to teach you guys how to position for them just in case if you ever come across it. But it's not very oftenly used, if that's the right wording. One good thing or one good practice to follow when you know you're going to do an image like this for your patients, and I know this sounds a little TMI, but you should really have your patients defecate before you take a sacrum or a coccyx image. A lot of the time, if they are full of fecal material, you're going to have a really hard time, especially on a coccyx, seeing those bones because they're so tiny. So we're going to go over both of those series together because they're pretty quick and relatively similar, but there are some differences that we needed to point out, and you may see it on a test or assessment, okay? So sacrum and coccyx, we use a 10 by 12. I always put them in portrait. Remember, if you're not sure what size cassette to use, try to visualize or think about how much anatomy are you evaluating. If it's a large amount of anatomy, then you're going to need to use the larger cassette. If it's smaller, you can get away with using the smaller size cassette. Now, sacrum and coccyx are both going to be at a 40-inch SID, and they both have tube angles, but they differ, and that's why I wanted to go over them a little bit more in detail. So it's an AP position. If you ever hear AP axial, axial means there's an angle to the x-ray tube. So sometimes you may hear a sacrum called as an AP axial, and that's because there's a tube tilt to the x-ray tube. Now, for this projection, I want you to put 15 degrees cephalad to the tube. Try not to get that confused with how many degrees are shown on the level itself. I want you to know how many degrees are you actually going to tilt it, not the calculation you would make from where you are sitting at 90, okay? Now, your central ray, honestly, you're going to see it described in many different ways, a few inches above the symphysis. Kathy likes to use this technique where you take your hands, put them together, and let them fall, and where the base of my hands are, go 2 inches above that, okay? Or, for me, I do almost the same thing, but I accomplish it a different way. I take the central ray and I come down about 1 inch to 1.5 inches below the ASIS, and I end up being in the exact same place. So you're going to find that other different techs have different ways of accomplishing the same thing. Doesn't mean that it's wrong. But if I were to test you on a projection like this, I would use what's in the lab manual, or I would say 1 inch to 1.5 inches below the ASIS instead, or I could say 2 inches above the pubic symphysis. It could go either way, but you end up in the same place, okay? Now, as far as collimation goes, for a sacrum, think of like your L5S1 spot. You could come in just a little bit. You could go 9 by 11, that's probably a little big. You definitely want to be a little longer because you want to make sure you get the entire sacrum from the top to the bottom. And your width, you could go from ASIS to ASIS because you need to make sure you get the whole sacrum, which is part of the SI joints. Just remember, your SI joints are medial to your ASIs. And then just center your patient with the vertical with their midline. So if you want, you can just ride their sternum all the way down. Right in the middle. Okay. Now, as far as a marker goes, it's really tough to figure out where you want to put it, right? So you've got your central ray where you want it on your patient. We got to line up the bucky and we got to put the marker on there. So Kathy's going to line up the tube, or the bucky to the tube. And then while I'm out of the actual light of the x-ray tube, she's going to place the marker in a corner that's safe. You know, the corners are always going to be safe space, usually, because you're never going to collimate so tight to the anatomy, ever. You always want to overlap a little bit, widthwise and lengthwise, to overlap your anatomy, because guess what? You're going to find some incidental findings more often than not, okay? So that's a safe place to put that. Now,
I want to just make sure.
Yeah.
I want to make sure that the central ray is where we talked about. So it's a little actually a little low. Do this. It's a little low. So I find it's a little bit low. I'm going to bring it up some. Okay. Good. Now I'm happy.
All right. Breathing instructions on this. You can just tell your patient to suspend if you want. The diaphragm isn't an issue in these. Diaphragm's a lot more superior than where we're imaging. So if you find that it's better for you to just tell your patient to hold their breath, don't breathe, don't move, and take the exposure so they don't move on you, that is okay. You'll find that if you tell your patients that, they're more concentrated on holding their breath than moving. So you'll have less chances of motion being on your image. Now, that's your AP sacrum. Now, I'm going to stay in the same position. We're going to do the AP coccyx. Now, the biggest reason you would think that you could do these images together as one, but you can't, okay? And that's a test question, just saying. The biggest reason why you can't is because the tube angle is different from the sacrum to the coccyx. So I've got 15 degrees cephalad for my sacrum. Now I need 10 degrees caudad for my coccyx. And if you think about it, it kind of sometimes curves up underneath. So we want to try to stretch it out and stretch it down into the inlet of our patient's pelvis. Central ray, go right about the ASIS. You want to go about 2 inches superior from the symphysis, but sometimes with that angle, it ends up being in the same place. So right at the ASIS is usually pretty close. Everybody's different. Everybody is different. This one is a big one with having your patients maybe defecate prior to taking this image. This one is the hardest one to see ever. It really is difficult.
Yeah.
It's really difficult. Collimation, you could maybe come in a little bit if you want. Smaller than the film size always. You could go 8 by 8 and still show that you're practicing good Alara technique while not clipping the anatomy. And then you just make sure that your marker was in the light. Okay? Breathing instructions the same as the sacrum. You can have them exhaling up. You can have them exhale hold if you want. You can tell them to suspend. It doesn't really matter. You can make that choice. It's always safer to tell them to hold their breath and don't move. Don't breathe, don't move. However you'd like to give that instructions. That way they just are focusing on that instead of wiggling on you. Okay? Now, we've done the APs. Now we need to do a lateral. I think I'm going to do a right so you can see behind me. All right, so you always have to have a lateral whenever you do an AP. When you do a sacrum and a coccyx, a lot of the time, these two images are sometimes taken together because if you think about it, look at the sacrum. The sacrum comes down and the coccyx is right below it. It's hard to collimate this little for a coccyx. It really is. So a lot of the time, we just do a 2-in-1.
Right.
So I'm going to do a right lateral just so you can see behind me. Now, your horizontal, is about the ASIS. Now, there is no tube angle for your lateral, okay? Now, where does the vertical go? Think about your anatomy, guys, right? When you look at someone from a lateral standpoint, or if you're looking and evaluating a sacrum, it doesn't sit perfectly lateral, right? It curves out. Kind of tends to ride with the curve of your patient's spine. So you want the vertical to be more posterior than anterior. So find your patient's ASIS and go about 3 or 4 inches posterior to it. And if you look close, you can kind of see the shadow of my tuchus in the light.
That's beautiful.
Make sure your collimation is between 10 and 11 because you want to make sure you got the top of the sacrum all the way to the coccyx. Make sure your patient is resting all the way up against that bucky so you don't have any OID. And you can just tell them to hold their breath, don't breathe, don't move, to prevent motion on your finished radiograph. Sound good? Marker, you make that choice. Where you'd like to place it. I tend to put it anteriorly up in the front, but I'm in a right lateral, so you need to use a right marker, okay? And where Kathy has it is in the front.
I guessed.
So then you would put it in the light and put me back.
Beautiful. Okay. Come forward a little. Yeah, right there.
Okay? So that's your lateral, sacrum, and coccyx. All right, guys. I know you've put up with us all quarter. We hope to see you soon in the clinic. Have a great day. Bye.